page again. So diagnosis of nipple-related disorders. I looked in internet at the National Institute of Health and Clinical Excellence, that is the organization writing the recommendation for UK. And if you look nipple discharge, you find that urgent referral concerning nipple with 2 weeks are the nipple eczema, the recent nipple retraction or distortion, and unilateral nipple discharge with stains close. When we talk about eczema, we have to be careful every time, because we know that there is the Paget disease, that is cancer that can be in situ or can be also invasive, that comes out from the breast, crossing the nipple. You see very well this picture, the cancer coming outside from the nipple, and this is the clinical aspects of the Paget disease. And this is the aspect, the classical one. It's not always so easy. You see microcalcification going to the nipple and the retraction of the nipple. This is an image from radiographics, because it's very nice to see. You see the invasive breast cancer into the breast, and you see the nipple interested from a Paget disease that is completely different from the contralateral nipple. But there are some conditions that require referral, not necessarily urgent. Nipple discharge again, bilateral discharge, sufficient to stain clothes in patients aged less than 50 years. Then we see the cause of the nipple discharge, because there are many things that can do the nipple discharge. The blood stain discharge in patient aged less than 50 years is urgent if it's unilateral, because if the discharge is bilateral, most probably will be because of hormonal secretion, not because of the pathology of the breast. And again, a nipple discharge in patients over 50 years of age. When it's not to consider normal, when it's bloody, when it comes from only one nipple, as I told, it comes out on its own without squeezing the nipple. If pregnancy has been rolled out, it's likely that the nipple discharge is caused by ductal ectasia, but it's harmless. And we see some images. A ductal papilloma, that is a benign tumor growing into the duct, and breast or nipple abscess. But we have to take into consideration that the nipple discharge could also be a sign of cancer growing into the breast. There are common causes of nipple discharge, as I told you. They could be contraceptives. I think it's very important for a radiologist to know all these things, because often the patient comes to the radiologist first, and we have to know if to perform or not, for instance, mammography or dactylography or ultrasounds. Fluctuating hormones from puberty or the menopause is it could be the same problem. I didn't talk about speaking about anatomy, but the same problem we can have with the male breast. Because of hormonal causes, we can also have the gynecomastia, so the increasing of the glandular tissue of the male breast. But sometimes we can have also a production of secretin. Previous breastfeeding, stimulation of the nipples, medication that cause Causes raised levels of prolactin include antidepressants and tranquilizers. It's important to know it. And because you can find gynecomastia because of in males because of drugs, but you can find also nipple discharge in women. Prolactinoma, and then hormone problems such as hyperthyroidism or Cushing's disease. When you find a nipple discharge, this is the flow chart I found. Nipple discharge is you can, if it's spontaneous, as I told you, if it's not spontaneous, you can have the evaluation of the secretum, and if it's negative, you can do anything. But if it's spontaneous, if it's from multiple ducts or it's bilateral, you can do anything. But if a single duct, first of all, we have to evaluate the serous and to make a laboratory examination. And if it's negative, we can decide if continue with examinations, radiological examination, or to stop the evaluation. If it's positive, we have to go to mammography or ultrasonography, and we'll see in the next slides. And I think the other part of the flow chart is not important for radiologists because it becomes interesting for endocrinologists and so on. So what to do when we have a missile discharge and we decide that it could be a dangerous nipple discharge, not hormonal, for instance. Apart the clinical evaluation, we have to proceed to cytology of the discharge, and then I'm convinced the ultrasonography has to be the first examination we can perform, and then mammography, photography, and MRI. If you can use very well ultrasonography, as Gianfranco Scaparotta told before, you can see quite everything. You see very well a papilloma here. This is a small duct, not so dilated. This is something growing into a duct that seems not to be a papilloma, seems to be something malignant into the dilated duct. And sometimes you are in trouble because you can't decide if it's a dense liquid or it's a papilloma. And if you switch on your color Doppler or power Doppler and you see a vessel into the image, you know that it's a papilloma. It's very nice to see. And if you're not able to find any lesion with ultrasonography, you can proceed to ductography. It's not so nice for the patient because you have to put a needle into the nipple. You see the needle with contrast media injection, and you see a lesion that seems to be a papilloma. In this case, you see a different pattern. Some ducts are interrupted, and there is a disorder that seems to be similar to the cancer. Looking at the indication of the EOSOMA, the European Society of Mastology, we find that there is not a recommendation to perform MRI in case of nipple discharge. But we are changing opinion, and if we look at the literature and if you look at the images, we can change idea in relation with MRI and nipple discharge. First of all, as I told you about anatomy, that's features on the mammography. If the ducts are dilated, they are hyperintense on T2 and hyperintense also in T1 if there is a bloody discharge. This is the case I showed you before. Was one of the first MRI performed about 15 years ago at my hospital. young patient with a bloody discharge from the nipple. We were not able to find a lesion. The cytology was positive. We identified the lesion at ultrasonography, at mammography, and we see very well the lesion, the cancer at MRI, and we see the blood coming out from the duct. So in case of nipple discharge, but also without nipple discharge, sometimes where, as I told you before about the lymph nodes, one of the first false positive finding at MRI at the beginning was where lymph nodes, intramammary lymph nodes, but also papillomas. And now we often can recognize papillomas at MRI. If you find a small spot of enhancement like this one, you see the region is behind the nipple, and we can think they could be papillomas. And if we are good in ultrasonography, and if we are lucky, we can find the duct and the papilloma inside the duct and to have the diagnosis. So without transmedia injection, intravenous transmedia injection of transmedia, we can anyway feel the defect in the duct. We can see irregularity of the lumen and identify ductal obstruction. If we inject contrast media intravenously, we can also see the lesion. So we can have the indirect and the direct image of the same lesion. And this is a nice example. This is before contrast media, two-weighted. You see the duct with the liquid inside that is very white, is hyper intense. And this is T1 after contrast media injection. And you don't see the liquid white as in T2, but you see the lesion. This is a subtraction. You see the papilloma into the duct because of the vascularization of the papilloma. Another example, papilloma at MRI, at ultrasonography, and you see the vascularization of the papilloma is similar, the curve is similar, at MRI is similar to the one of the cancer. Some other example from France and from Italy is from Torino. This is the case with nipple discharge, bloody, serious nipple discharge. The cytology was C3. And you can see this was the image at ductography, mammography, and this is the MRI, and this is a traction, and this was a papilloma. In this case, a bloody nipple discharge, we see the lesion very well at MRI. This is the mammography, and with ductography, it's not enough to have a diagnosis. In this case, we find a lesion that is similar to the duct, and he was a DCIS. This is an Italian work on this topic. They evaluated 38 patients with clinical suspicion of nipple discharge, and the value of sensitivity were very interesting. 140 MRI versus 40 of mammography and 40 of mammography plus ultrasonography, and the specificity was higher than one of mammography versus the low specificity of MRI. So sometimes we have to perform with all the techniques to have the answer. MRI, which are the advantages of MRI in case of nipple discharge? It's not invasive, you don't use X-rays, low risk of complication because you don't put any needle into the duct. The lesion is directly visualized, and you can characterize, measure, and localize the lesion. Another example, in this case, they found some microcalcification. This is a case from Rome. Behind the nipple, this is the galactography, and this is the MRI. You see an invasive ductal carcinoma, much better at MRI than ductography. So you have to know all those things, because in this case you see microcalcification, maybe you have a biopsy of the lesion, but thanks to the MRI you can measure the real lesion and tell the truth to the surgeon or to the oncologist to go straight to the therapy. Again, another paper on nipple discharge. They demonstrated that the positive predictive value of thermogalactography is 19%, the one of EMRI is 56%, and the negative predictive value is 63, the one of galactography versus 87 of MRI. We know that one of the best things of the MRI is the negative predictive value. Often not in the 100% of the cases, but very often close to the 100% if you don't see any enhancement of MRI. Most probably there is not a lesion. Some authors try to use special coils, the finger coils, to evaluate the nipples and the area of the nipple, but I think we can simply perform a normal breast MRI that we do every day. There are some take-home points concerning the MRI. There is a nice sensitivity and specificity. It's a panoramic view of the lesion, and you can see the duct without injection, just with a two-weighted image, and so you can localize the lesion and make biopsy or to guide the surgery. All mammary ducts are fully included in the field of view. Usually when you perform galactography, you see just one, the one that has discharge. In this case, you can visualize other ducts. The visualization of proximal and peripheral ducts, and the detection of additional intraductal lesion, also in different ducts, as I told you. And I think it's finished. Thank you for the attention.
Thank you very much, Professor Pietro, for this very informative presentation on a very important topic of nipple discharge. And now we call for Professor Gianfranco, presenting current role of tomosynthesis in diagnosis.